Sydney Cancer Genetics explains, referring patients and their families to cancer genetic specialists. Hi, I'm Dr. Hilda High, a genetic oncologist. I work with Sydney Cancer Genetics at the SAN Clinic, part of the Sydney Adventist Hospital in Wahroonga, Sydney. This presentation is an extract from a talk I gave to the advanced trainees in medical oncology. It's designed for doctors, GPs, as well as specialists working in cancer, such as surgeons, radiation oncologists, and medical oncologists, who want more information about how and why to refer a patient with cancer or a family history of cancer to cancer genetic specialists. Let's start with familial or hereditary cancer services. These services are staffed by doctors such as oncologists, surgeons, or geneticists who have specialised in the understanding and management of inherited cancer. They often work closely with genetic counsellors. One reason for seeing a genetic oncologist is to understand your or your family's lifetime risk of getting a cancer. This is achieved by taking a detailed family history, confirming the types of cancers reported, and using modelling tools to estimate risk. Discussions of the heritability of cancer can be complex as well as emotional. The benefits and limitation of genetic testing are always discussed before any genetic testing is performed. This includes the management strategies to reduce cancer risk, whether or not a test is undertaken, and also whether or not a change in a gene, known as a mutation, is found or not. There are many reasons why an individual with cancer should be referred soon after their diagnosis. In some circumstances, a different treatment option would be recommended. Also, if there's a fault in a gene that's being passed down in the family, the patient may be at risk of other cancers. There may be other family members at risk of cancer, and in some cases, an individual may make different reproductive choices, such as choosing to have IVF with pre-implantation genetic diagnosis to prevent the mutation being passed to the next generation. Cancer is a genetic disease, and it's also a common disease. For example, 1 in 10 women will get breast cancer around about an average age of 60 years, and 2 out of 3 people will have some kind of cancer over their lifetime. Why did I say cancer is a genetic disease? It's because mutations or mistakes occur when a cell, such as a breast cell or a bowel cell, divide and have to copy all of the DNA in their nucleus. These mistakes, which tend to be random, are important when they are in genes involved in growth, cell death, such as apoptosis, or in cell migration. They take time to accumulate, and that's why most cancer occurs at an older age. However, because they have occurred in a local cell, they can't be passed on to the next generation. Cancer syndromes, by contrast, are usually caused by a mutation in a key gene, one that's involved in growth or cell division, or in the finding and fixing of genetic mistakes. In this situation, the random mistakes that are made in a cell can build up faster, and we tend to see either more cancers running in a family or cancers occurring at a younger age. So how do you know when to refer? The easiest rule of thumb is the 3-2-1 rule, that is, 3 blood relatives in 2 generations with 1 person diagnosed under the age of 50. Patient characteristics can also be a clue, such as cancer occurring at a young age, multiple cancers in a patient or in their family, and certain syndromal features or cancer clustering, such as particular skin lesions or macrocephaly, or other types of cancers occurring together, such as bowel and uterine cancers or breast and ovarian cancers. There's also a role played by ethnicity, and that is because of something referred to as founder mutations. For example, in people of Ashkenazi Jewish heritage, the mutations in the BRCA1 and BRCA2 genes are significantly more common. Sometimes the cancer itself provides the clues. This can be due to the pathology of the cancer. We can perform certain tests on a bowel cancer, for example, that can demonstrate loss of staining for the mismatch repair proteins, and this can be a significant clue to an inherited cause of a bowel cancer. At other times, it may be the type of breast cancer that is the clue. In this case, triple negative breast cancer. That is a cancer that is negative for both the ER and PR receptor, as well as the HER2 receptor. Rare tumour types and bilateral or multifocal tumours are other clues. If you want to find more specific information, you can find some simple guides on our website under the Doctor's FAQ tab. Alternatively, for very detailed information, the Cancer Institute's FAQ website is an excellent resource. I work hard with my colleagues to ensure that the information on this site is evidence-based and clinically relevant. Here's an example of the referral guidelines for breast and ovarian cancer. There are guidelines for many other cancers, including bowel cancers and polyps, gynecological cancers, endocrine cancers, and many others. Here I've summarized the guidelines for breast and ovarian cancer referral. There are specific ages and types of cancers that should definitely be referred, and these include a woman who's diagnosed with breast cancer under the age of 30, a woman diagnosed under the age of 40 with a triple negative or basal-like breast cancer, a woman who is diagnosed with bilateral breast cancer with her first diagnosis occurring under the age of 50, and pretty much any male breast cancer should be referred. And these 4 categories are regardless of any other family history. Within ovarian cancer, it's thought that 10% are caused by an inherited mutation. And as a result, ovarian cancer diagnosed under the age of 60 is a reason for a referral to a cancer geneticist. Also, breast and ovarian cancer occurring together or a family history of this should also prompt a referral. Slightly more complex situations include a woman with a triple negative or basal-like breast cancer and a family history, 2 first or second degree relatives with breast cancer if one occurred under 40 years or if both occurred under 50 years, and in a woman who has a family history of 3 or more first or second degree relatives with breast or ovarian cancer. It should go without saying that anyone with a personal or family history of a hereditary cancer syndrome should be referred for a discussion regarding genetic testing. Many doctors don't know how to take a quick, accurate family history. Here are a few key points using a case study. In this situation, a mother with breast cancer at the age of 58 attends with her daughter, aged 27. You quickly ask if there's any other history of breast cancer, and as you can see, there is none. Just to explain, a first-degree relative of the daughter is her siblings and her parents. It would also include offspring. And in terms of second-degree relatives, these would include her aunts and uncles and her grandparents. So what is this young woman's risk? Fortunately, the National Breast and Ovarian Cancer Centre has devised some risk categories and some guidelines. You can find these the most easily by Googling the title, Advice about Familial Aspects of Breast Cancer and Epithelial Ovarian Cancer. So what would you say? What is this young woman's breast cancer risk category? Is she at average risk, moderate risk, potentially high risk or high risk? Well, if you said average risk, you'd be right. This is because breast cancer is common, and so having a close relative with breast cancer diagnosed at an older age is not unusual. However, a common error especially when considering breast or other female-related cancers, is to only ask about the maternal history. As you're well aware, half of our genes come from the paternal side, and in this case there is a strong paternal history. What do you think the risk is now? In fact, her risk is still only average. In order to reach the moderate risk category, which covers only 4% of the population, you need to have 2 second-degree relatives, that is, an aunt and a grandmother in this case, diagnosed with breast cancer, but at least one of them needs to be diagnosed before the age of 50. As I mentioned, a key role of familial cancer clinics is to confirm the pathology of the cancers. In this family, the presentation of the query cervical query uterine cancer was actually more consistent with an ovarian cancer, as it was associated with abdominal bloating due to ascites. This was later confirmed on the death certificate. Also, a bit more questioning revealed the recent diagnosis of bilateral breast cancer in a young cousin, and it may well have been this diagnosis that prompted the daughter's questioning in the first place. So now what would you say is the risk? In this situation, the risk is potentially high, and that's because we have not yet identified a specific mutation associated with a high risk of breast cancer. So, how do you actually find a cancer genetics specialist? One very good resource is the Cancer Institute of New South Wales database at the CanRefer website, www.canrefer.org.au. By typing in the type of cancer and typing in the location where the patient lives, you can find a familial cancer centre close to your patient. In addition, Sydney Cancer Genetics provides a telehealth service for individuals living outside of the major metropolitan centres, and you can see our website for further details. You now know what familial or hereditary cancer clinics and genetic oncologists do. That is, they are involved in the assessment of inherited risk, the genetic testing and counselling that entails, and in cancer prevention and risk management. A list of these clinics and genetic oncologists can be found through the Cancer Institute's website, CanRefer. And you know the red flags that should prompt a referral, such as the 1-2-3 rule, cancer occurring at a young age, a family member with more than one type of cancer, or specific types of cancers occurring together in a family, the presence of rare cancers, or a particular type of a common cancer, and of course, patient interest. More specific guidelines can be found at the EviQ website. More of these videos can be found on our YouTube channel or via our Facebook or website. Thank you.